Alright, so welcome back. Today we're talking about Chapter 10, which is Respiration and Artificial Ventilation. This chapter goes hand in hand with Chapter 9, so I'd highly recommend that if you have to review Chapter 10, review Chapter 9 as well, and vice versa. If you're reviewing Chapter 9, review this chapter as well. So this is kind of the continuation of airway management. This gets into some more of the pathophysiology of respiratory disorders, as well as how we can take over breathing for a patient. So more airway management techniques and things that we do. So some topics we're going to be covering in this is physiology and pathophysiology. That should largely be review at this point from previous chapters that we've done. Respiration, which is some review. Then we're going to get into some new stuff with positive pressure ventilation, oxygen therapy, some special consideration, and then assisting with advanced airway devices. So that would be assisting your paramedic with some advanced airway things that they do. So let's dive into physiology and pathophysiology. Like I said, most of this should be review at this point. So hopefully this won't take too long. We can kind of fly through some of this. So if you remember, we have ventilation and respiration. Ventilation is the actual moving of air in and out of the lungs. Again, I use the term air vent to remind myself of what ventilation is, because air vents move air versus respiration is the actual exchanging of gases. So ventilation, remember, is the actual moving of the air. So again, review. When we inhale, our diaphragm goes down. Our muscles expand, so that makes the area inside your chest bigger, which puts negative pressure inside the chest, which causes air from the outside, which hits higher pressure, to rush into the area of lower pressure, and that will fill in the lungs and fill in the space that is created by the diaphragm going down. So that's our simple mechanics of breathing. Again, this should be reviewed at this point. And the opposite, when we exhale, it's more of a passive process because your diaphragm relaxes, so the diaphragm goes up, creates positive pressure inside your chest, and air doesn't want to be in an area of high pressure, so it goes back out to the atmosphere, which has lower pressure than what's inside of your chest. Again, this should be review. Some more review from our pathophysiology talk. Tidal volume, that is the amount of air moved with one breath. And minute volume is your tidal volume times your respiratory rate, and that measures the amount of air that moves in and out of your lungs per 1 minute. So remember, this is very similar to cardiac output and stroke volume, but when we're talking about lungs, it's tidal volume and minute volume. So more review, we have the dead space. If you remember, that is the space between your mouth and nose and your actually alveoli, and that space is space that cannot actually exchange gases, because gases only exchange at the alveoli level. So since that air can't exchange gases, it just kind of sits there. It fills up the empty space, so we call that dead space air. Okay. And then remember, alveolar ventilation, that refers to air that actually reaches your alveoli. And diffusion, or respiration, is the movement of gases from a high concentration to a low concentration. So when the air is sitting in the alveoli and the blood comes through in the capillaries, the blood that comes there is high concentration of carbon dioxide, low concentration of oxygen, and the air sitting in your alveoli that you just breathed in is high concentration of oxygen, low concentration of carbon dioxide. So the air inside your lungs, the high concentration of oxygen wants to go into your bloodstream because it has a low concentration, and inside your bloodstream, the high concentration of carbon dioxide wants to go into the alveoli, which has a low concentration of carbon dioxide. So they move until they equal themselves out. So that's diffusion, which causes respiration. Again, this should all be review at this point. So we can put respiration into two different categories. We have external and internal respiration. So external respiration, that is respiration that occurs between the atmosphere, so outside of our body, and us. So that's the diffusion of oxygen and carbon dioxide between your alveoli, which is your atmospheric air, and the circulating blood, versus your internal respiration. That's what's happening inside your body. So that's the blood and the cells actually exchanging. So your internal respiration makes cellular respiration happen, if you remember back to our pathophysiology talk. So speaking of cellular respiration, when blood comes to a cell, oxygen comes from the blood, goes into the cell. Carbon dioxide, which is the waste product, goes from the cell to the blood. That's cellular respiration. Once again, I'll review at this point. So pathophysiology of your cardiopulmonary system. We've talked about a lot of this so far. It's anything that disrupts the mechanics of breathing or anything that disrupts the circulation in the body. So if you disrupt one of those, you're going to have a disruption in the entire cardiopulmonary system, which will then lead to a failure of that system. And that's usually what leads to shock. So again, all this is review. This should all be familiar to you guys at this point. We've kind of been drilling this in. So all that being said, let's move on into some more fine aspects of respiration. So as you know, and this is going to be a little bit more review too, your brain and body needs a steady supply of oxygen. The cells inside of every structure in your body need oxygen to make ATP effectively. Remember back to our pathophysiology talk. And so we always need a constant fresh supply coming to the body. And if that doesn't happen, you get what's called hypoxia. Remembering back to your medical terminology lesson, we'll break down the word hypoxia. We got hypo, H-Y-P-O, so that's your prefix. And then XIA is your root word. So that is low, because hypo, low oxygen. So that means low oxygen. So if you do not have a steady supply of oxygen, you become hypoxic, or you get hypoxia. One of those two terms work. On the other side, we also, since we deliver oxygen, we need to take that carbon dioxide away and remove it from the body. And if we don't remove it from the body, then you start trapping it inside your body and you become acidotic, because carbon dioxide is an acid. And if we have specifically high levels of carbon dioxide, it's what we call hypercapnia. Hypercapnia. That, if we break that down, we have the prefix right here, hyper, meaning high, and then capnia, so we have the NEA, that's breathing, and cap is carbon dioxide. So it's high levels of carbon dioxide. It's usually, we detect that by actually measuring the amount of carbon dioxide you're breathing out. And so that's why you have the NEA suffix at the end of breathing, because we're measuring it from breathing out. So you're breathing out high levels of carbon dioxide compared to what you should be. So those are two terms that we have to know, hypoxia and hypercapnia. So when we're assessing adequate versus inadequate breathing, which are covered in airway management, we're really assessing how well your cardiopulmonary system is accomplishing bringing oxygen to your cells and removing your carbon dioxide. Because as we know, anything going wrong in that process is going to lead to a failure of the entire system, which eventually leads to shock, which will eventually lead to death. So that's why we have to continuously assess your breathing status. So if something goes wrong in the system, as you know, the body always tries to compensate for it. So if your body notices that you are hypoxic or you're hypercapnic, then it's going to do some pretty predictable things to compensate for this. If you think of what logically would happen, that's what the body does. So one thing that you want to do, or the body wants to do, is increase your respiratory rate and depth. Because if we don't have enough oxygen, one of the ways that we can get more oxygen in the body is make more minute volume happen. So to make more minute volume, you try to take more of a breath, which increases your tidal volume, and you try to increase your respiratory rate. So you increase both aspects of what makes up your minute volume, and you should have more oxygen coming into your system. Vice versa, you should have more carbon dioxide leaving the system because you're breathing more out. So that's one way that your body compensates for that. And it will also increase your heart rate, because if you increase your heart rate, you start circulating more of the blood around, you can deliver more oxygen to the cells that are being deprived of it, and you can remove more of the carbon dioxide that is being produced. So both of those kind of go hand in hand. If your body's compensating, your respiratory rate and depth go up, as well as your heart rate. Now, when you have both of these happening, you're going to have a symptom, that's something you feel, of shortness of breath. You're feeling like you can't get enough air in you. And that's your body's way of telling you that something's wrong. We need to get more oxygen into us. So that's a complaint that we are often going to see in the field, is someone saying, I feel like I can't breathe. That's your body's way of saying, we're compensating for something. We need to fix a problem somewhere in our system. So the body is pretty good at compensating, but it's not the end all be all. The body compensating is like putting a Band-Aid on a cut. If it's something small, the Band-Aid works. Yeah, it's going to stop the bleed. It's going to make things better. But if you just got cut up with a knife and it's a 10-inch cut down your arm, putting a Band-Aid on it is not going to help. It's going to maybe stop a couple drops of blood, but you need some more definitive care. So early on, your body does a decent job, but then at one point, it's not going to be able to compensate for everything that's happening. So during this period where it is trying to compensate and it's keeping up with the needs, this is called respiratory distress. So if you see respiratory distress, that's an increased work of breathing. So your respiratory depth goes up, your rate goes up. You're going to notice that they're a little tachycardic, so have a faster heart rate. This is all things that we see in what we call respiratory distress, and that's where the body is actually keeping up with the need. So your perfusion is still doing okay. You'll then move on into complete inadequate breathing. That's when your body, again, cannot compensate. That's putting the Band-Aid on the 10-inch cut, and your body just can't keep up with the demand that it has for some reason. This is what we call respiratory failure. Now, this is why it's really important for us to catch respiratory distress before it moves into failure. It's kind of like shock. We want to catch shock early. We also want to catch respiratory distress early, because respiratory distress left untreated will oftentimes turn into respiratory failure. And if respiratory failure is left untreated, no matter what, you're going to be going into most likely respiratory arrest. So respiratory failure, once you've reached that point, you're going to be tumbling down into an area where you can't breathe at all. And that's what arrest means, is stopping of breathing. So you have no respiratory effort or drive whatsoever, which if you do that, shortly after is going to be death. So right here's a picture of someone who's in respiratory distress. There are a few things that we can see in this picture that tell us. The blank stare down, because she's focused on her breathing. She's leaning forward a little bit, and her hands are on her legs. That's called tripoding, because you're in a tripod position right there. And that helps take some of the stress off of your chest. It takes some of the weight off your chest right here to help your muscles work a little bit better. Same with having your shoulders pointed up like this and your head leaning forward. This, if you remember from chapter 9 with airway management, this is called the sniffing position. So her head is forward because she has a lot of work of breathing going down right now. In class, I showed a couple videos of live patients with respiratory distress, so you can see their work of breathing happening and what it actually looks like in real life. So when we get into assessing our patients, which that's going to be 2 chapters from now, when we're looking at our patient, we want to look for signs that we have adequate breathing happening. And adequate breathing happening oftentimes are the same signs that we look for adequate perfusion, if you think back to shock. So if someone's breathing normally or adequately, they should have a relatively normal mental status. They should be talking with you. If you are hypoxic for any reason, one of the first things to go is your mental status. You're going to be a little bit altered, sometimes a little combative. So as long as they're talking with you, you know that their brain is getting a decent amount of oxygen to it. You should have relatively normal pulse oximetry readings. So pulse oximetry, we'll talk about it in a lot more in vital signs and monitoring devices. Pulse oximetry is one of those tools that is very oftentimes misused. So what it does, you put it on someone's finger, it shines a light, has a sensor on the back, and it reads the amount of hemoglobin that have particles attached to them. If you remember back to anatomy and physiology, hemoglobin are the things on red blood cells that carry oxygen. So in theory, when we're doing a pulse oximetry reading, you're seeing how much of your hemoglobin is filled with oxygen. You want to have that number usually above 92%. So 92 to 100% is considered normal for a pulse oximetry. There's a few issues that come with pulse oximetry. One of which is a lot of times you don't get an adequate reading. If someone has fingernail polish on, it's hard to shine that light through a finger and get an adequate reading. If someone's hands are cold, so they don't have adequate blood flow to their actual hands, then you aren't going to be getting adequate reading. If you have any other thing on a finger, like dirt, sometimes will alter the reading. So sometimes the readings will be altered, and sometimes it's reading adequate or properly, but it's not reading the right thing. That's something that we'll talk about in some more respiratory emergency things. But carbon monoxide, not dioxide, monoxide, so CO, that sometimes can be leaked in a house. And carbon monoxide, the reason why it's dangerous is it sticks to your hemoglobin, and it sticks a lot better than oxygen does. So you can have someone who is very hypoxic who happen to be in an area of carbon monoxide poisoning, and your pulse oximetry is going to be reading 100% because it's reading that all your hemoglobin are filled, but all your hemoglobin are being filled with carbon monoxide, not oxygen. So yeah, that's a somewhat rare occurrence for us to encounter. We do see it in the field every now and then, but it's something to keep in mind that pulse oximetry, while it's a great tool, it's not your end-all be-all. So it's a number. It's a number that you should definitely take into account to read how someone's doing, but it is not your end-all be-all. This will dictate all of our treatments. This is where the saying, treat your patient, not your monitor, comes into place, because sometimes numbers don't line up with what the patient needs. So treat what you're seeing in your patient. That's why we're going to teach you how to properly assess your patient. And these numbers are great tools, but they don't always tell us the whole picture. So we want relatively normal pulse oximetry readings. Sorry for that little tangent. And again, those relatively normal would be 92% and above. And then we're looking for a relatively normal skin color. So we want skin to be slightly pink because that means that blood is flowing near the skin, which is what a healthy person does. So we're looking for relatively normal. If it turns blue, that's a sign that there's not enough oxygen in your blood. Your blood is going from bright red to dark red, so it's going to show up as blue or purple sometimes. Or sometimes if you aren't perfusing well enough and your blood vessels start retracting into your body, you're going to start looking really pale. So all these are signs of your adequate breathing status. These are things that we want to see when we're assessing our patients. On the flip side, some signs of inadequate breathing, and we covered these in Chapter 9 as well. You want to look for your chest movement. Remember, look, listen, and feel for your chest. So you want to make sure that your chest is actually moving up and down. If they are absent or barely moving or uneven, those are signs that you aren't moving enough air. You got your abdominal or belly breathing. There's a video that showed there in class that actually shows someone with some belly breathing. Not being able to feel or hear air moving at the nose and mouth. So that comes back to your look, listen, and feel. You're listening for air movement. You're feeling for air movement. You're feeling for a chest rise. You're trying to look for the chest rise. Listening for breath sounds. If they are diminished or absent, that's a sign that you don't have good breathing. And then any of your adventitious, which means bad, lung sounds. And again, we're going to go through all these lung sounds during respiratory. And once again, I can't emphasize enough that you guys should be listening to as many lung sounds as you can, especially on healthy people. I want you guys to know backwards and forwards what good, normal lung sounds sound like. So we can identify very quickly when it's not a normal lung sound. That's really big during this class. I want you to be able to know what's normal lung sound versus not normal lung sound. Some more signs of inadequate breathing. Look at the rate of breathing. Is it too slow? Is it too fast? The normal rate of breathing that we should be looking for in an adult is around 12 to 20 times a minute. So you're going to have to start to memorize some normal vital signs. That's one of them. 12 to 20 times a minute is what we're looking for. So if someone's breathing 4 times a minute, that's not enough to get good enough minute volume because the number's too low. And if someone's breathing 30 or 40 times a minute, that indicates that something's not moving right. Your body's trying to compensate for it. So you are breathing really, really fast, which oftentimes will blow off too much carbon dioxide, and you won't be able to take in enough oxygen. Look to see if their breathing is shallow or deep. So it should be a pretty normal depth that you and I share all the time. But if someone's trying to take big, deep gasps, that's usually a sign that something's not right. Or if they're breathing very shallowly, that's usually a sign that there's an obstruction somewhere. Cyanosis, that's the term for blue capillaries or capillary beds. So that's where we're looking at like your fingertips, and your fingertips should always look pink. That's a sign of good perfusion. And again, if you don't have enough oxygen, it's going to start turning blue. And when we see blue on these capillary beds, either on your fingernails, on your lips, or on your ears, any area of very thin tissue, that's where we get what we call cyanosis. This is a big sign of inadequate breathing and a sign that someone is hypoxic. Having very long, drawn-out inspirations, or more commonly expirations, that's usually a sign that there's an obstruction that you're trying to get around. So if someone is taking a really, really long breath out, that is a sign that there's inflammation in your lower airway and you can't push the air through as quickly. So that's why they have to really push all that air and use a lot of force to get all that air out. And that's a sign of inadequate breathing. You're looking at nasal flaring in kids. So that's where the sides of the nose go out, and that creates an open or bigger passageway for air to come in. You're also looking at retractions, which that's when the skin kind of sucks down, especially if you look above your clavicle in a kid, and the skin is going to suck down when you take an inhale. That's because of the negative pressure when the diaphragm goes down, negative pressure inside the chest. But the lungs don't fill up enough, so all the skin kind of sucks into that negative pressure environment. And then a low oxygen saturation reading. Now, this is kind of an older presentation. It was made in 2016. So it says below 95% in here. It's really about 92. So that number has actually gone down in recent years due to some more studies of SpO2 readings. So if that number is 92 or below, that's when we start thinking of inadequate breathing. Okay. So when we have inadequate breathing, there's two options that we can do. Sometimes we can do them both together. And the first one is we give supplemental oxygen to the patient. We have a few different devices that we can deliver supplemental oxygen with, and we'll be talking about those in a little bit. And another thing that we can do is provide artificial ventilation. So that's where we are actually taking over, forcing the air into lungs. We do that with what's called a bag valve mask, which we're going to talk about in depth and we're going to be practicing with in depth. So those are our two big things that we can do to help fix inadequate breathing, is give oxygen, and if needed, take over ventilating the patient. Remember, ventilating is moving the air. So we actually take over that action of ventilating. So that poses a question. When do you intervene in a call? At what point is a patient so bad that we need to do something about it? This is not a black and white answer. It's not a black and white question. It's really patient dependent, and this is where experience is huge. Now, I can teach you everything in this textbook. I can teach you everything there is to know to pass a New York State EMT exam. I can do that. What I can't do is go out there and have you meet these patients and see them over and over and over and over and over again and learn what these things look like in real life. That's going to come with time. That's going to come with experience. So recognize that when you become a brand new EMT and you go out into the world, there's a lot more for you to learn. And it's what's going to bring you from a smart EMT, because you'll be smart when you come out of this class, to a good EMT. A good EMT has a lot of experience to back up how smart they are. So going back into this question, most of your respiratory failure patients, they are going to be conscious still, and they're still going to be breathing. So look at how hard they're breathing, and that will gauge how much oxygen you should give, which again, we're going to be going over our different methods of giving oxygen. We can give different levels of oxygen. So if you see that they're having a little bit of distress or failure, we give a little bit of oxygen. If they're having a lot of distress or failure, we give a lot of oxygen. And then if they really aren't moving enough air, so they aren't ventilating themselves well, even if they're conscious and even if they're breathing, that's when we have to start to go into taking over their ventilation for them. If you find that they are in respiratory failure to the point where what they're doing is inadequate for their body's needs, you have to act immediately. So look at what your body's telling you. If your body is telling you that it's compensating and it's still going down, so your body can't compensate for what's going on, you have to take action somehow. So again, it's not a black and white answer. This is something that you just have to go out and see. This is why when you become a new EMT, you don't just go out on your own. You ride with someone else watching you for a while so that you can start to see these things and get this experience that will give you the proper judgment to answer questions like, when do I intervene? So a question they want you to think over is, what signs might identify the need to intervene in a breathing patient? And again, this is kind of a judgment call, but like I said in the previous slide, usually if you look at the patient and their body is showing you signs that it can't compensate for what's going on, that's when we really need to intervene. Sometimes when the body's compensating, we still want to intervene a little bit, help the body out. But really, if you see the body's going downhill, we have to intervene right away. So moving on to positive pressure ventilation. It's a weird term, but if you break it down, positive pressure means you're pushing that pressure into the lungs, and then ventilation is us moving the air in and out. So we are creating an environment where we are putting positive pressure inside of the lungs. So textbook definition is forcing air or oxygen into the lungs when a patient has stopped breathing or has inadequate breathing. It uses the force exactly opposite of how the body normally draws air into the lungs, because remember, when we normally draw air in, we're doing it with negative pressure. So the diaphragm goes down, create negative pressure, air passively goes in. When we're doing positive pressure ventilation, we are pushing air in and creating a positive environment inside the lungs ourselves. So we aren't waiting for the body to give us negative pressure. We are forcing that air in with a positive force behind it. So there's a reason why we don't always do positive pressure ventilation in patients. In fact, it's usually a last resort for someone who is having active respiratory failure. And that's because there's a lot of negative side effects for positive pressure ventilation. One of the biggest ones is called gastric distension. So gastric distension is if we push too much air, then your lungs won't accept it. Or if your airway is not open, like we discussed in airway management, we didn't open it up properly, the air is going to go down your esophagus, not your trachea. When it goes into your esophagus, it's going to go into your stomach. It's going to start inflating your stomach like a balloon. And that's not good because your stomach doesn't like being blown up like that, so it's going to want to discharge whatever's in it, which it does by vomiting. It will contract and vomit to get all that air out. Problem is, when it gets all the air out, it's going to take all of the gastric contents out as well. So that's going to start traveling up and go back into your airway, which is going to cause an obstruction, like we talked about in airway management. And the obstruction, for someone who's already not having a good day breathing, is just going to cause a lot more problems. So we have to be very careful to not cause gastric distension. Now, gastric distension and hyperventilation, that means too much ventilating, they kind of go hand in hand, because if you hyperventilate the patient, the chances of gastric distension go up dramatically. And we as providers, unfortunately, tend to hyperventilate our patients. It's usually because of adrenaline in us. When we're in an emergent situation where someone's not breathing, we have to take that over for them. We tend to breathe too fast for them. It's even if you're counting out loud, usually you're not counting, or you're counting too fast, so you aren't going to be delivering oxygen or ventilations at a proper rate. So we can hyperventilate the patient, which can cause gastric distension. It can also overinflate the lungs, which can cause a lung to tear because of so much pressure inside of it, which causes what we call a pneumothorax. We'll talk about that a little bit more in chest trauma. You can also trap air down there. If you're breathing too fast, you won't be able to have air coming back up and exhaling. So you're going to be trapping your carbon dioxide in your lower airway because it can't get back up before you put more positive pressure, forcing it back down. So those are two of the big things that we look at for negative side effects. And also, a negative side effect is we can decrease our cardiac output. The reason why that can happen is if we're putting positive pressure inside of your thorax or your chest, that positive pressure can push on your heart because your heart is in your chest cavity. So if we put too much pressure in the lungs, we overinflate them, it starts squeezing your heart. If your heart squeezes, it's not going to be able to get the proper preload because it can't relax enough, so it won't be able to put out as much blood. If you don't put out as much blood, you decrease your cardiac output. In turn, you're going to drop your blood pressure because your heart's not moving blood well enough, which is pretty bad to happen when you're already talking about someone who has a failure of their respiratory system. You want your cardiac system to be performing optimally to help compensate for the failure of your respiratory system. So going after your heart and decreasing the cardiac output when you already have a decreased respiratory output is not ideal. So when we actually go to ventilate a patient, so we use the bag valve mask and we are forcing air into the lungs. Few techniques that you want to follow, and we're going to be doing this in person quite a bit. So do not ventilate a patient who is actively vomiting. This is because someone who is pushing vomit out of their airway, you don't want to put pressure to shove it back down the airway. This is why we do suctioning, which we talked about in Chapter 9. So if you have someone who is actively vomiting, it doesn't mean that you can't ventilate them. Just suction the vomit out first so you aren't pushing down into the airway, because that's not going to help anyone. When you're ventilating, you want to see chest rise, and you only want to ventilate to the point where you see the chest start to rise. As soon as you see chest rise, that means you put enough air in, so you stop ventilating at that point. And then you want to see the chest go back down. You want to see the exhalation happen. You want to make sure that your rate is adequate. The rate that we want to ventilate at is about 10 to 12 times a minute. So that equals around 6 seconds. Every 6 seconds you should be wanting to take a breath. So make sure that your rate's not too slow, so you aren't doing it every 10 seconds. That would be too slow of a rate. And make sure you aren't going too fast, which is what we tend to do. So make sure that you don't go below 6 seconds. Because if you go every 4 seconds, you're going to be ventilating a lot more than you need to. When you have a conscious patient, you want to make sure that you have a good, accurate assessment of how adequately they're breathing. If, like I said, if they are conscious, you want to explain it to them, because if you have a bag valve mask, you need to have a very tight seal on the patient's face. So you're pushing a seal over their mouth and nose, or a mask over their mouth and nose. They're going to feel like you're suffocating them, which is not a good feeling when you're already having a really hard time breathing. So explain it to them. Tell them what's happening. Tell them the benefits of it. Tell them what they're going to feel and experience. Otherwise, you're probably going to cause a little bit more harm than good. We place the mask covering their entire mouth and nose. Then we want to seal it, like I said. And if the patient's still breathing, when they breathe, you breathe with them. So you're helping push air in as they're trying to take a breath. This is what we kind of call assisted ventilation, because they're still breathing and we're just supplementing their ventilation for them. So we're helping push air further down their airway because they can't do it on their own well enough. So you can either have full ventilation where they're not breathing, or their breathing is so bad that they aren't moving any actual air in to have adequate ventilation. Or you can have assisted ventilation, which is where the patient is in respiratory failure, so they're not doing a good enough job. They need your help, but they still have a good organized control of breathing. So we have several different forms of delivering ventilation, or positive pressure ventilation. The main one that we use is called a bag valve mask, which we'll cover in a little bit. Another main one that we use is called CPAP. Hospitals use what's called BiPAP, but we in the field use CPAP. CPAP stands for Continuous Positive Airway Pressure. So that means that there is always positive pressure inside your airway. It's always forcing that air in. BiPAP stands for Biphasic Positive Airway Pressure. So these are forms of non-invasive positive pressure ventilation. What we mean by non-invasive is this supplements someone who is conscious and I'm talking to you, but needs assistance ventilating. So that person I talked about, that they're conscious and when they take a breath, you're just helping force some more air in. You can do that with a bag valve mask, but it's not nearly as effective. The bag valve mask to our conscious patient, I actually refer to it as redneck CPAP, because it kind of works, but it's not the best. So if you are equipped with CPAP, that's really what we want to be using. So CPAP is a big mask that we put over your face. We strap it to the back of your head so it has a good seal, and it is constantly forcing air at you. So it does not shut off. It's just blowing air really, really, really fast at you. And when you take a breath, that air that's being forced at you is now forced into your lungs. So it's putting pressure or positive pressure inside of your lungs every single breath that you take, and it's doing it based off of your spontaneous breathing. BiPAP is a little bit different. Like I said, this is what hospitals use. We don't use BiPAP in the field, but BiPAP won't deliver the positive pressure 24/7. It'll register when you take a breath, and it will deliver the positive pressure at that moment when you're actually taking the breath. So it's not constantly coming at you. It's only when you take the actual breath yourself. BiPAP is much more comfortable for patients, a little bit less intimidating for patients. CPAP is very loud. BiPAP is a lot more quiet. But it is important to know the difference between the two, and that the hospital is most likely going to take them off of your CPAP and put them on their BiPAP. Now, we do have mouth-to-mask ventilation. This is something that I've never done or seen done in my career because we have bag valve masks. So this is where you breathe from your mouth straight into a mask that is over the patient's face. It's not nearly as effective, and it puts you at greater risk for picking up a disease from the patient. So it is an option. We have not used it in very, very long time in EMS. This is what a pocket mask looks like. That's what we use for mouth-to-mask ventilation. So you have your mouth goes over this valve right here. This is a one-way valve here to try to protect some pathogens from getting back up at you. Then this goes over the patient's nose and mouth. So that is a pocket mask. Lay people you might see using it, like lifeguards might use it, but we in EMS, we have better tools. So this is one of those where they need us to explain the actual mechanism of what we're doing, but we're going to go over this in class, so we'll just kind of fly through this real quick. You want to open up the patient's airway. As long as they don't have a suspected spine injury, you do the head tilt chin lift. You put the mask on the patient's face, and then you blow through the one-way valve. You do that, and you blow just enough to see chest rise. So these are the written out steps. Here's the rest of the steps. This is a picture of it actually happening. All right, so moving on into bag valve mask, or BVM for short. So we're most likely going to refer to this as a BVM from now on. So this is what we actually use to ventilate a patient. We usually use it for someone who's not breathing at all. We can use it for a breathing patient. Like I discussed earlier, we can do it manually for the redneck CPAP. But generally, when someone's conscious, we want to do CPAP instead. So BVMs come in 3 different sizes. You have adult, child, and infant. The reason why we have the different sizes is it helps us not overinflate these populations. So an infant one is going to be designed more for smaller lungs. So that, if you use an adult one, you squeeze all of it, you're going to pop both of the lungs in a child or an infant. So we're just using that to help us not overinflate the lungs. Now, overinflation is a big thing that we watch out for. An adult BVM has about 2,000 milliliters or 2 liters of space that it contains. A normal adult, their tidal volume, so what we normally want to breathe at, is about 500 milliliters. So if we have a 2 liter bag and we only need 500 milliliters for adequate breath, that's 4 times what we need normally. So this is where it's critical to watch just for chest rise and not go beyond that point, because if we go beyond that point, we're going to be overinflating the patient's lungs, and that's very easy to do with bag valve masks. Right, so some mechanics behind BVMs. We want to attach them to oxygen. We want to turn that oxygen up to at least 15 liters per minute. There is a bag at the back of a BVM, and that is a reservoir of oxygen, so that the bag and part of the BVM can refill with oxygen very quickly. So we have a backup reservoir that will help fill that after we take a squeeze of it. When we squeeze the bag, the air inlet closes, and pure oxygen is delivered to the patient. When you release it, the patient has passive expiration that comes out of the valve that will shut back down. And again, most of this stuff is a lot easier to show in person and to do it in person, so that will really seal in a lot of the stuff. So when you have no trauma suspected, we strongly recommend that you do 2 rescuer BVM. 2 rescuer BVM means that one person is dedicated entirely to ensuring a good seal of the mask to the face. So that oftentimes takes 2 hands. And then the second person, their job is to just squeeze the bag. So if you have the extra hands, 2 person is what we definitely want. A lot of times, unfortunately, in EMS, we don't have enough hands to go around. So a lot of times we end up doing 1 rescuer BVM ventilations. So as the slide says, the most difficult part of ventilating a patient is having an adequate mask seal. It's really hard to maintain that seal with just 1 hand. So 2 rescuer is really what we want to do, but oftentimes we can't. So, going through the steps, you want to open up the airway with your head tilt chin lift as long as there's no cervical spine trauma. Make sure that you have the right size bag for the right size person. So an adult gets an adult, a kid gets a pediatric, and an infant gets an infant. You should be above the patient's head. Position your thumbs over the top half of the mask and index fingers over the bottom half. The mask is a triangle shape. You want to put the tip of the triangle over the bridge of the nose and the lower part of the triangle over the mouth and upper chin. You want to make sure that you maintain your head tilt chin lift and bring up or lift up the head with the mask. So the person who has the mask seal is also doing the head tilt chin lift to open up the airway. So second person will squeeze the bag, and that's their only job. And when they release the bag, the patient is passively exhaling. So if you have C-spine trauma suspected, you do the exact same steps, except you open the airway using a draw thrust maneuver. So here's a good picture of two people doing the BVM ventilations. You can see this one person is holding the mask with both hands, and the second person is squeezing the bag. Once again, much easier to show than to talk about. So one rescuer BVM operation, this is, like I said, going to be most of the time what you're going to have to do. Again, a lot easier to show on a mannequin in person. We're going to open up the airway, get the right size mask, and then we use what's called the CE method. So your index finger and thumb make a C, and then your middle finger, ring finger, and pinky finger make an E. The C goes around the mask, and the E goes around the jaw. So that's how you apply pressure to the mask and keep it tight to the jaw at the same time. And then the rest of the operation is the same. You squeeze the bag and you release the bag, and the patient should exhale passively. So when you do BVM ventilations and you're not getting results, so you're not seeing that chest rise, you need to start thinking, what am I doing wrong? Why are we not getting the chest rise? The most common reason why is you don't have the airway opened properly. So reposition the head, get the back into that head tilt chin lift, because most of the time you don't have enough of a good passage into the lungs. So that's going to be your solution to the problem most of the time. The second most common one is not having a good seal around the mask. So air is leaking out of the mask instead of being self-contained and going straight into the body. You usually can hear or see that, or sometimes feel it. So that one's a pretty easy one to check for. And then also check for any airway obstruction. So any of the foreign bodies that we talked about, something they might need to suction out. Anything that prevents air from getting from point A to point B. Whether it's in the BVM, sometimes the patient can vomit, and vomit can get back inside of the BVM. Sometimes there is some sort of obstruction inside the airway. Sometimes it's a problem with the smooth muscle inside the lower airway to where it's so constricted we can't move air through. So that's another thing we have to take into consideration when we don't have proper chest rise. And it says to use an alternative method. Usually if you check for these three things and fix one of those three things, that should get you where you need to be. So a special consideration that we have are people with stomas. Stomas are the holes in your trachea. So it's a direct passageway. It's usually done for people who have throat cancer. So we have a few special things that we have to think about with stomas. So you're going to be putting the BVM with the mask over top of the stoma, so it's actually going to be over top of the person's throat, right where the stoma is. Make sure that there are no mucus plugs or secretions in there, so suction those out if there are. Again, only as far as you can see. And you can leave the head and neck in a neutral position this time, because opening up the airway, doing the head tilt chin lift, is to manipulate the upper airway. The stoma is directly into your lower airway, so you don't have to mess around with having to open up the airway with your head. So that's some of the things that we look at. Continues on the next slide. Ventilation, we do the same thing. We want to ventilate about 10 to 12 times per minute for an adult. And if you can't artificially ventilate through the stoma, try to seal it off somehow. You can put like a plastic bag over their neck to try to get a good seal there. You can try to hold your hand there, although a lot of people might think you're trying to choke them out. And then you're moving back to your conventional through the mouth and nose. But you need to make sure that that stoma is sealed. Otherwise, all the air that you put through the mouth and nose is just going to go back out the stoma. It's not actually going to reach the lungs. So now we can talk a little bit about ventilators. Ventilators are used in hospitals. They automatically deliver positive pressure ventilations. You can change how often they deliver, so you can change the ventilation rate. You can also change the ventilation volume. They are very helpful, especially for long-term care, because it delivers a nice and precise rate and volume every single time. It's very consistent, so it's nice to use. The issues behind it is it sometimes takes a while to set up, and they are expensive and they are bulky. So not a lot of ambulances have automated ventilators. I've only worked for one company in my career who's had one, and no one ever used it. So be aware of them. You'll see them in hospitals all the time, and you have respiratory therapists who've spent years training on these ventilators, and they can set them up very quickly. There's a lot of settings and a lot more adjustments you can make with a hospital ventilator. But a lot of EMS agencies don't use it because it takes up a lot of space. So most of the time we're using manual ventilations all the way to the hospital. But if your agency does have a ventilator, try to familiarize yourself with it, and be sure that you know how to use it in an emergent situation so that you aren't trying to fumble around with all the settings while you're treating a patient. Make sure you know how to do all those well beforehand. They are great tools if you have one that you can use. Here's a picture of an automated transport ventilator. It says that this little coin right here is to show how big it is for scale. So you have a few different options here of settings. You have your breaths per minute, you have your tidal volume, you can select if it's an adult or child. So it's a very, very, very simple setup. The ones in the hospital you can adjust pretty much any type of setting that you want. So yeah, again, be familiar with it. Most places aren't going to be lucky enough to have one of these. So how would you decide which positive pressure delivery method to use for your patient? General rule of thumb, as long as you have the equipment, if they're conscious and can talk to you, CPAP is the way you want to go. If they're unconscious, BVM is the way that you want to go. That's the general rule of thumb. And of course, this is medicine. Things can change per patient. That's generally what you want to follow. All right, so moving on into oxygen therapy. So a lot of people think that oxygen is harmless because it's oxygen. It's in the air. Everyone breathes it. Oxygen is a drug. It is a medicine that we give to our patients. Oxygen can actually do patients some harm. We're going to talk about that in a little bit. And you should really assess your patient overall and every condition surrounding the patient, including their medical history, and use that information to decide if you want to give oxygen or not. So it's not some harmless thing that we can just throw on everyone. So a lot of people ask us for oxygen that don't need oxygen, and that's an important thing that we need to do, is explain to them why they don't need oxygen at that time and why we shouldn't be giving oxygen, because it can do some harm. So in terms of how we carry oxygen, we have two different main ways of carrying oxygen. We have what are called portable tanks. Usually these are D-sized tanks. Oxygen tanks are measured in letters. The bigger or the further down the alphabet you get, the bigger the tank it is. So a D tank is smaller than an M tank. So portable tanks are usually D-sized. We'll see a picture in the next slide. It says they're lightweight. They're still a little heavy. They are safe and dependable. Usually you want to have about 2,000 psi in your tank, and if you get below usually around 1,000 psi, that's when you want to switch your tank out. The other way that we carry oxygen is on board. It's a big, usually M-sized tank installed inside the ambulance, and that will carry a lot more oxygen. That's what we use during transports, because that tank will last a whole lot longer. Same rules of thumb, you want to be about 2,000 to maybe 2,500 psi, and anytime you get below 1,000, with the onboards you can usually push it to 750, but that's when you really want to be thinking about changing it out. It really depends on how close your agency is to the hospital. If I'm working North Shore Ambulance in Cleveland, which the closest hospital is 45 minutes away, I'm changing that out at 1,000. If I'm working Eve's Ambulance in East Syracuse, where I can get to a hospital in 5 to 10 minutes, 500 to 750 is when I'm thinking about changing it out. So here's some pictures of some portable oxygen tanks. This guy right here is a D tank. And this guy right here would be about an E or F tank. So these both are portable oxygen tanks. Right here is a oxygen regulator. So that little air dial right here, when you look at it, that'll tell you how much pressure is in the tank. And we're going to go over how to put the regulators on the tank and how to use the tank. So we're going to be doing this to no end. So don't worry about not getting it right away with these pictures. Here's an example of an onboard oxygen tank. So this is the tank right here. You can see all the straps that are on it. And this system actually has a remote. It's this yellow guy right here. And that remote you can use to lower the tank down. So the hydraulics will actually bring it out of this cabinet and down. And that's how we change those tanks out. So those tanks last a very long time. They are meant for use during transport, versus the portable are meant for use on scene. So you can carry that tank to the patient on scene. You use it until you get into the ambulance, then you switch over to your main tank. So, like I said, it comes in various sizes. Your D tank, which is the tank that we usually use for portable, has about 350 liters of oxygen in it when it's fully charged up. And your M tank is usually what you are going to be using for onboard. That carries about 3,000 liters. So almost 10 times what a D tank carries. That's why we can use it for a much longer period of time. You also can go all the way up to G or H tanks. Those are pretty darn big, so most ambulances don't carry them because it just takes up too much space, and they are incredibly heavy to move. So like I said, they have regulators, which will show you how much pressure is in the tank. And then we also have tubing that's intended to use for oxygen. We're going to go over all this stuff. We have wrenches that we use to open and close the oxygen tanks. And when you put a regulator on, you do have some gaskets and valve seat inserts that sit inside the regulator. So we just want to make sure they are, one, present, and two, not damaged. So when you open the valve of an oxygen cylinder up, you want to spin it all the way open, and then once you hit the part where it stops spinning, just go close a half turn. That way, if someone comes after you and they think that they need to open up the oxygen tank, they don't turn into the fully open position and think that it's either one, that it's broken, they need to try to keep on shoving it that way to open up, or two, they think that they're closing it since they hit resistance, so then they go to what they think is open it and it's actually closing it all the way. So as you go just a half turn back, then it's going to be most of the way open, but it'll still have play on both sides so that someone else will know that it's open. When we're storing our oxygen cylinders, make sure it's in a cool ventilated room and it's properly secured. You don't want these guys falling over randomly. And your agency should hydrostatically test your oxygen cylinders every 5 years. That just tests the pressure, make sure that the tank can handle the amount of pressure that's in it. That's something that you guys don't really need to know. So it's just we have to cover it area. Definitely don't let cylinders drop or fall. Usually when we have a cylinder like on a table or something, you lay it on its side so it can't fall over. And we'll go over this in class. And also this seems obvious, but don't let anyone smoke around oxygen. Oxygen will feed fires very, very, very well. It's one of the things a fire needs to burn. So having a tank of pure oxygen that's leaking out around anything that is burning is not good. So if you see anyone in the house that's smoking, politely ask them to either leave or put the cigarette out before you use oxygen. Yeah. So it says never use oxygen around an open flame. Never use grease, oil, or fat-based soaps on devices that will be attached to an oxygen supply cylinder. Don't use adhesive tape on a cylinder, and don't try to move an oxygen cylinder by dragging it or rolling it on the side. Some pretty common sense. Just treat an oxygen cylinder with, treat it carefully. Don't be doing anything stupid with it. So your oxygen regulators, they, for one, tell you the amount of pressure that's in the tank, but also will reduce that pressure so that it's not blowing 2,500 psi back at you. It's going to reduce it down to 30 to 70 psi, and that's what's going to be the amount that we can actually administer to a patient. That way we aren't blowing their face off. And in the regulator is something called a flow meter that allows us to pick how many liters per minute of oxygen is coming out of the tank. You have a low pressure or a high pressure flow meter. A low pressure one is the one that we use on pretty much all of our administrations of oxygen. That's the one that will go on our portable tanks. And it allows usually up to 15 liters per minute of oxygen to flow out. You have high pressure flow meters. Those are ones that you usually use for ventilators and CPAPs. Those can go up to 25 liters per minute. So most of the time we're going to be seeing the low pressure flow meters, but we do have certain circumstances if you're using BiPAP or a ventilator that we will have a high flow meter. That just means that we can deliver more oxygen. Here's two different types. One right here, this guy has a little ball on the bottom, and you turn this knob right here. It's going to bring the ball up. You can see the markings, 5, 10, and 15. That's the amount of liters per minute that you're delivering. So you just bring the ball up to whatever amount of liters per minute. You see, this is what we see on a lot of onboard ambulance tanks. Right here, this guy is a typical one that we see on a portable tank. So you have your pressure gauge right here. Then this dial right here, you twist. You can see 4 and 6, 10, 15 on there. You just twist it to, there's usually an arrow marking either here on the side or on the top. You just twist until that number gets to the arrow that you want, and that's the amount of liters that you're putting out. So right here, this is your low pressure side. So oxygen will come out of here. This is the regulator. It shows you the pressure in the tank. This is your selector for the liters per minute of the low pressure side. So right here, this guy is your high pressure side. So you can screw something in. You can see it's threaded. You screw something into this side, and it will depress that little button right there, and that will allow high pressure to come straight from the tank to here. It bypasses this side, goes straight through here. This side can be used at the same time as this side. So an instance that we might use that is we connect CPAP right here, and then we connect a nebulizer right here, because you use a nebulizer and CPAP at the same time. So humidifiers, something we don't typically use in EMS. Humidifier is used to make the oxygen or whatever air we're delivering a little more moist, because a lot of times our mouths and nose, if we're giving high flow oxygen, can't moisturize that air as well. It's something that's used in long-term oxygen delivery. So if people have at-home tanks or compressors that they use, or people in the hospital, humidifiers are something that you're going to see used there. In the short-term setting of EMS, we typically don't need to use them, which is why you don't see them all too often. But it is definitely an option that we can do, especially if you're doing a long distance trip, like a 5 to 6 hour transfer to New York City or something like that. So your humidifier is this tank right here. You can see your oxygen tubing connects to it, and then this screws into your flow meter. So he's selecting 3 liters per minute. It's flowing down in here, getting humidified, and then coming out of this port to go to whatever device you're using. It probably was for a nasal cannula. So some hazards of oxygen use. It's mainly surrounding the tank. If the tank gets punctured or a valve comes off, it can shoot out very fast, and it is pretty heavy, so it can become, as it says, a missile. It'll be a projectile flying somewhere. And oxygen supports combustion, so that's why we are very adamant that you can't smoke or have open flame around it. And it can float around where we're delivering it. So if you're giving it to a patient through a mask, it will come out of the mask and then surround their face. It's going to surround the bedding that they're in. It might surround their clothes. And so you can have someone light a match at their feet, and since the oxygen has spilled out, it's going to cap or be at the feet and combust up there and make their way all the way back up to the face. So also remember that oxygen and oil do not mix under pressure very well. So like we said at the start of oxygen administration, there are some negative side effects that oxygen can have. In infants, if you have pure oxygen flowing over their eyes, you can cause eye damage, because that's not what their eyes are meant to experience, is that much oxygen flowing at them, especially at that pressure. There's also, so if you remember back to talking about respirations and what makes us breathe, it's our chemoreceptors, and they measure high levels of carbon dioxide. And that is our main drive to make us breathe. If carbon dioxide gets a little too high, it tells us that we need to breathe that carbon dioxide off, so we take a breath. In some people, mainly people who have what's called COPD, chronic obstructive pulmonary disease, COPD, one of the downsides of it is you usually have higher levels of carbon dioxide in your blood for a very long period of time, because you can't breathe it off as well. And so the people who have chronically high levels of carbon dioxide, their body is not going to respond to that drive to breathe as well. And so your body has a backup system. It's called your hypoxic drive. And that backup system, if you break down the words, hypoxic, so low oxygen, and then drive. So that backup system is driven by you having not enough oxygen in your blood. So that's not usually our main drive to breathe, because, as we said in our pathophysiology discussion, your carbon dioxide levels change a whole lot quicker than your oxygen saturation levels change. But if your carbon dioxide receptors don't work as well anymore, because they think that your levels need to be much higher than they are to breathe, then your hypoxic drive will kick in. So if you have someone who is dependent on their hypoxic drive to stimulate them to breathe, and then you start flooding them with oxygen, you then tell that drive that your body has enough oxygen in it, so it's not going to stimulate you to breathe anymore. So it could theoretically lead you to having respiratory depression or even respiratory arrest, because your body thinks that you have enough oxygen, so your hypoxic drive doesn't kick in to tell you to breathe, and your normal chemoreceptors aren't telling you to breathe because your CO2 levels have been high for so long that your body thinks that that's normal. So you end up not breathing for a very long period of time. It's not that common. As this slide says, it's a rare medical situation, but it is something that we need to be concerned about, is your hypoxic drive and giving high flow oxygen to patients who might be using their hypoxic drive and giving it for a long period of time. This is usually something that you only see with a lot of oxygen administration for a long period of time. Usually not something that we see in the acute EMS setting, so please do not withhold oxygen from a patient because you're afraid of this. It is something that might happen, but the chances are so low that we would rather you give oxygen than not. these situations. So on the skills day, we're going to go over all this type of stuff. As these slides point out, oxygen tanks themselves can be dangerous, so just follow my instructions on how to safely handle them. They more or less are pretty safe to work around. Just don't be stupid around them. That's the biggest thing. So when it comes to administering supplemental oxygen, we have a few different options we can use. The first one is called a non-rebreather mask. This is the gold standard for supplemental oxygen delivery. This is the most oxygen that we can deliver via device without actually ventilating the patient. So if you remember back to shock, atmospheric air has 21% oxygen. That is a number you have to remember, 21% oxygen. So if you think back to your body with your minute volume, your body really wants to keep that minute volume at the same level. So if something happens to you that you can't get enough air in for some reason, your body's going to compensate for that to try to keep your minute volume the same. So think back to your tidal volume. Tidal volume in an average adult male is about 500 milliliters. Now think about your dead space. Dead space is that space that you aren't exchanging any sort of gas. So take that 500 milliliters and subtract 150 milliliters because that's your dead space. So that space that's not doing anything. So that means that you have 350 milliliters of air that actually reaches your alveoli. So if you remember, only 21% of that 350 milliliters is actual oxygen. So that's roughly 75 milliliters of oxygen that reaches your alveoli for gas exchange, which at your baseline, everything's normal in your body. That's perfect. That is what we want. We want just about 75 milliliters of oxygen reaching our alveoli every single time we breathe. Someone who is in some sort of distress, it could be an airway obstruction, it could be some swelling in the airway, it could be increased demand for oxygen in your body. They're going to have decreased minute volume, usually because you can't get enough tidal volume. So your body will increase your respiratory rate to try to compensate for that. One thing that we can do to help with that is, if we can't change the tidal volume because of something going on in the body that we can't fix, we can give supplemental oxygen to make it so that the oxygen that actually reaches your alveoli has a much higher concentration of oxygen in it. So instead of 21%, if we change that and made it 100%, then you take that 500 milliliter tidal volume, which would be a normal person. You then subtract your dead space of 150, you get the 350 milliliters. And if we're breathing 100% oxygen, then we're getting 350 milliliters of oxygen to our alveoli versus the 75 that we were getting at baseline. So that comes into play, say, if you have only a tidal volume of, we'll say, 200 milliliters because you have something obstructing your airway, and you subtract the 150 of dead space, that leaves you with 50 milliliters normally, which 21% of that is only 10 milliliters of oxygen that gets to your alveoli. So that would be someone who's in extraordinarily respiratory distress, probably going into respiratory failure at that point. But if we take that 50 and we're giving 100% oxygen instead of the 21, we keep it at 50, which is still not enough. So your respiratory rate is still going to be a little bit higher to try to drive that number of minute volume up. But it's 5 times better than what the patient was having before. So it's going to help them out significantly, and they're going to start feeling better significantly. All that being said, we have to think about how much distress the patient is in, and that will help us select what device to use. So a non-rebreather delivers between 90 to 100% oxygen. So remember that number. Atmospheric is 21%. A non-rebreather properly fitted will deliver between 90 and 100% oxygen. So this is the best that we can get short of actually ventilating the patient ourselves with positive pressure ventilation. So here's a picture of a non-rebreather mask on a patient. You have an oxygen reservoir right here that is fed by this oxygen tubing. So this is what the patient is actually breathing from. So it's 100% oxygen coming in. You have these one-way valves that allow air out but no air in. So make sure that these two one-way valves are intact. You then have this metal band that goes over the nose. Pinch that tight to get a good seal. And then you have this spring shaft that goes around their head on both sides. And you pull that tight so that it fits all the way around their mouth and nose and under their chin. And it should form a good seal. A good fitting sealed non-rebreather will give you 100% oxygen. We say it goes down to 90% because most of the time there's a leak somewhere. Here's another picture of a non-rebreather mask. We will show these in class, and we are going to be using these in class. So as I said, it delivers about 90 to 100% oxygen. Textbook says 80. It's usually 90 to 100. The flow rate that you put a non-rebreather at is between, you can actually go down to 10, but 12 to 15 liters per minute. So you can go down to 10, but your optimum flow is 12 to 15. The reason we say this is because that's the flow that it takes to keep that bag inflated at all times that you breathe out of. So, excuse me, 12 to 15 is what we look at. You can go down to 10. So, moving on to nasal cannula. A nasal cannula will deliver less oxygen and delivers a lower percentage oxygen. It depends on your flow rate for what percentage you get. But nasal cannula sits inside of your nose. You have two nasal prongs that go inside your nose. I'm sure everyone has seen these used. It then wraps around your ears and then goes below your chin, and you pull up a little slider to make it tight against the chin. It's a good choice for someone who refuses to wear an oxygen mask, so a non-rebreather mask. Also, someone who's actively vomiting, you probably shouldn't have a mask on them, so because you're going to vomit into the mask and it's going to go back into you. So that's usually active vomiting is usually a contraindication for a non-rebreather mask. So anytime that we're contraindicated for a non-rebreather, we go to our nasal cannula. Nasal cannula looks like this. And the concentration, you bounce between about 24 and 44% oxygen. So it's way better than atmospheric oxygen. You can more than double your amount of atmospheric oxygen. But it's not nearly to the level that a non-rebreather can deliver. So this does work well for people with very mild respiratory distress because it will boost up that amount of oxygen that's being delivered. This is something that you see given to people who have long-term issues with keeping their oxygen levels up. Some people wear nasal cannulas 24/7. Some people wear them as needed when they feel short of breath. Some people wear them every night to bed. So these are what we see a lot for long-term treatments. For your flow rate, you should be delivering between 2 to 6 liters per minute. So 2 is pretty much the lowest end that we want to be on, and 6 is the highest end that you want to be on, mainly because it's a lot of air to be blasting up nostrils after you get above 6 liters per minute. So 2 to 6 is the flow rate for a nasal cannula. Non-rebreather was 10 to 15. And your oxygen concentration is between 24 and 44 for nasal cannula, and 80 to 100, I like to say 90 to 100 for a non-rebreather. These are need-to-know numbers. So your atmospheric percentage, your nasal cannula percentage and flow rate, and your non-rebreather percentage and flow rate. Some things that we personally don't use in EMS, but you might see being used at nursing homes. One is called a partial rebreather mask. It looks pretty identical to a non-rebreather mask, except it doesn't have the one-way valve opening into the reservoir bag. You'll get about 40 to 60% oxygen, and you set it to around 10 liters per minute. This is more informational stuff. This is not stuff that we're actually going to be doing. So just know that these exist, and you might see them, especially if you're taking care over from another healthcare provider. A Venturi mask, which you'll see in the next slide. Again, not something we use, but it delivers specific concentrations of oxygen because it will mix your oxygen with inhaled air together. These are used a lot in hospitals just because you can be a little bit more specific with how much oxygen you give. Non-rebreathers are great. They give high flow oxygen, but you don't want to be giving high flow oxygen for a very long time. So that's why Venturi masks, you can start to wean them down on oxygen levels. And some of them have a set percentage and flow rate, and others just have an adjustable port. So Venturi mask looks like this. So down here you have your adjustments. And that comes through here as it mixes with atmospheric air, and then you breathe it through the mask. Here's another view of it. You notice it does have two holes at the sides here. So it does not have the one-way valves that, say, a non-rebreather mask would. So tracheostomy mask, this is actually something that we do carry and we can use. So the Venturi and the partial rebreathers we don't use in this state with EMS, but tracheostomy masks we do. That's for stomas or tracheostomies. So it's the cutout in your throat. And you place this over top of them, and it will help provide supplemental oxygen. You usually use about 8 to 10 liters per minute. I'm going to show you a picture of it in the next slide. So right here you have the mask. It goes over the stoma, so this part goes over the stoma. You got this green strap that will go over top of the neck. And then this connects to tubing, which you can then connect to your oxygen source. Not something we commonly use, but when we need it, we really need it. So this was just a video of giving oxygen administration via a non-rebreather. We are going to be doing this several times in class, so we did not watch it. All right, moving into some special considerations. Again, same with airway management. Facial injuries can make a lot of this stuff difficult. If you have blood or swelling, or if it's a traumatic injury and you're missing parts of your airway, that can make all the stuff pretty difficult. Make sure you're aggressive with suctioning, and if you have anything with facial injuries or anything affecting the airway with injuries, it's probably a good idea to get an ALS intercept coming to you, because ALS does have a lot more advanced techniques that can bypass a lot of the issues that we might encounter. Obstructions. Make sure that you clear the airway of any foreign bodies that can make it so that we physically cannot put air inside of the lungs. If you can't ventilate and you've checked all the other boxes off of you've opened up the airway, you've thought of any medical causes behind it, always think obstruction. So make sure that obstruction is something that you have a high degree of suspicion for. Just like in airway management, dentures can become issues. If they are in place and they're secured, leave them in place and work around them. if they get dislodged or they get in your way, you can remove them. And be aware that they can sometimes get dislodged and go to the back of the airway, and you might not know about it. So make sure that you have a good thought of where dentures are if you see a patient that might be wearing them. So when thinking about kids, be aware that kids will burn oxygen about twice as fast as adults. They breathe a lot faster, their body uses a lot faster because their bodies are growing a lot faster. So hypoxia will set in very quickly. One trend you're going to see with kids is they'll maintain and be fine, and then crash hard. Adults, you usually see like your heart rate goes up, your respiratory rate goes up, your body compensates pretty well, and then you start to deteriorate. Kids usually look fine, and then just fall off and they're done. So be very mindful when you're dealing with a kid that just because they look okay now doesn't mean that they're going to be okay in 5 minutes. And be aware that they do need a lot more oxygen than adults. That's why the respiratory rates are a lot faster. If you're ventilating a pediatric patient, make sure that you avoid excess volume. That's why we have the smaller bags. And it's usually a high stress situation, so you're going to want to be breathing a lot faster and counting a lot faster than what's really needed. Make sure that you get an appropriately sized mask. You are not going to be using an adult mask for them. Using flow restricted or oxygen powered ventilation devices are contraindicated for kids. So this is where we're doing manual maneuvers. They do make pediatric non-rebreathers and nasal cannulas that fit their faces a whole lot better, so make sure we use those. And gastric distension may impair adequate ventilation. So again, do not overventilate these patients because gastric distension will affect them a lot more than it does adults, and it affects them a lot quicker too. So be very, very careful when it comes to peds. All right, so moving on into assisting with some advanced airway devices. This is usually going to be assisting the paramedic that you're partnered with or a paramedic that you call for with things that they do. So a lot of this is kind of just know the background of it. You can, by all means, get more information from paramedics that you work with. You can ask them to show you some of the advanced stuff that they do, some of the advanced tools that they have. It will only help your knowledge. So paramedics, we have a lot of devices that require us looking straight at the glottic opening. So we look straight into the lower airway, and then we can insert a tube straight into the trachea. When we insert a tube straight into the trachea, that will isolate the lungs. The tube comes out the mouth, and then we can attach the BVM to that tube, and so we are breathing straight into the lungs. We bypass all of the upper airway. There are also some devices that we insert blind. That means that we just kind of shove it into the mouth, and we usually have markings to know how far down to go, and then it's going to isolate the glottis or the epiglottis. So we can usually inflate two cuffs, one above and one below the glottis. That's going to isolate the glottis, and so it should isolate your lower airway, but it's placed in your upper airway. So here's a picture of a paramedic that is doing what's called intubation. That's the direct visualization of the glottis and placing a tube straight into the trachea. So intubation, that's what we just saw a picture of. A lot of times an EMT is going to be assisting a paramedic with that procedure. And a lot of that comes with preparing the patient for intubation. So a lot of times I'll be setting up my equipment while my EMT partner is going to be ventilating the patient using the BLS maneuvers that we've talked about. And I can ask them to pre-oxygenate the patient. That means that you're going to be hyperventilating for a little bit and pushing a lot of oxygen into the patient. We do that because during the intubation attempt, the patient is going to be going for 30 to 45 seconds with zero ventilation happening. So we want to maximize our oxygenation before we go through that period of them getting no oxygen. We are going to place the patient in a sniffing position. Remember, sniffing is kind of reaching your nose out like you're sniffing a candle. We might ask an EMT to provide cricoid pressure. Cricoid pressure is if you feel for your Adam's apple and go just a little bit below your Adam's apple and then push down. That will help lower some of the airway structures so it's easier to see. We might ask you to help confirm the location of the tube. So if we place the tube and we isolate the lungs, you should be able to listen and you should hear lung sounds in the right side and in the left side of the chest. And you should not hear sounds coming from your stomach. So when we need to confirm that the tube is in the right place, we listen to the stomach to make sure that we don't hear air movement going in there, because that means that we put the tube in the esophagus. And then you also want to listen to the right side and the left side of the lung sounds, because you want to make sure that, one, it's in the lungs, and two, we didn't put the tube too far and it went into one of the main stem bronchus, and so we only isolated one lung and the other lung is not getting any air whatsoever. So that's something that we could help you or have you help with is confirmation. Then lastly, we can have you help securing the tube in place. They have commercial tube holders. We'll show you one of those in class, and they kind of go into the mouth and then screw down onto the tube and then strap around the back of the neck. And it should keep that tube in place. So those are some things that we might ask you as an EMT to help us with. When someone is intubated, the intubation tube can come out very easily. So making sure that that tube does not move is paramount to maintaining the patient's airway at that point. So make sure it doesn't pop up or it doesn't move side to side. So keep it very still. Make sure that everything remains consistent. If you're ventilating the patient and air is moving very freely every time that you bag, then all of a sudden you have a lot of resistance. That means something's happened. Whether it's in the lungs or in the tube, something has changed. And so you need to tell your paramedic immediately any change in how hard it is to ventilate the patient. If the patient is defibrillated, that means that we have to clear the patient away from any provider so we don't accidentally get shocked as well. Make sure you take the bag off of the endotracheal tube. If you just leave it sitting there, the BVM is very heavy. So the BVM will kind of slump the endotracheal tube over, and it's not going to, it might help the tube dislodge. So make sure you take the BVM off. And since you're up at the head ventilating the patient, you are in prime condition to see if the patient is changing in mental status, if they are opening their eyes, for example. Some of these patients we have to medically sedate, so we give them medications to put them out before we intubate them, and those medications wear off. So if you see that the patient is showing signs that they are regaining consciousness, you need to tell your ALS provider about that so that we can re-medicate them. If you have someone who has a traumatic injury, especially to the airway, and they are being intubated by the paramedic, we might ask you to provide inline stabilization, so holding the C-spine still throughout the entire procedure. When you do that, you want to make sure that the neck doesn't move, but allow the mandible to move, so the jaw can be moved by the paramedic. So make sure that you hold the head and the neck steady, but make sure that the mandible can be moved. So that was all about intubation. That's where we have direct visualization of the glottis. Again, this is not a procedure that you guys are going to be doing at the EMT level, but you will very much so be helping an ALS provider do this. And we also have blind insertion devices. There's many different ones out there. Some of the newer ones are the King LT Airway. We also have what are called iGels. That's what I currently use is called an eye gel. And these are big masks that you can blindly just put into the mouth and then shove a certain distance, and that should isolate the trachea. So it's a lot easier to put in. There's actually talks of this becoming BLS sometime in the next few years, that BLS riders can put this in because it requires very minimal skill. Yeah, it's a blind, you put it down in an airway and then you test to make sure that's actually in the correct spot. So here's a video of in-hospital intubation. All right, moving on into some chapter review. Respiratory failure is a result of inadequate breathing that is insufficient to support life. A patient in respiratory failure or respiratory arrest must receive artificial ventilations. Oxygen can be delivered to the non-breathing patient as a supplement to artificial ventilation. Oxygen can be administered as therapy to the breathing patient whose breathing is inadequate or who is cyanotic, cool and clammy, short of breath, suffering chest pain, suffering severe injuries, or displaying altered mental status. Remember, whenever you are managing an airway, always use your proper PPE. Assessment of breathing must be an ongoing process. Respiratory status can change over time. Just because when you met the patient they were doing okay breathing does not mean they're going to be okay later. An inadequate breathing requires immediate action. Keep in mind that positive pressure ventilations are very different than normal breathing and can have negative side effects. Select the most appropriate method of positive pressure ventilations based upon the needs of the individual. Remember to always use appropriate safety measures when handling oxygen. Remember to select the appropriate oxygen delivery device to provide supplemental oxygen. So, just think about what are some of the signs that we might see for respiratory distress, or some signs that we might see for respiratory failure. For BVM ventilation, what are recommended variations in technique for 1 or 2 rescuers? How does the way positive pressure ventilation moves air differ from how the body normally moves air? If you remember, body normally works off of negative pressure. So positive pressure is the opposite, where we're forcing the air in instead of having the air kind of passively come in for the negative pressure. Describe a patient problem that would benefit from administration of oxygen. Explain how to decide what oxygen delivery device should be used. So this would be a good example, would be an asthmatic patient who is having difficulty breathing. You could give a non-rebreather to them, and as we discussed, an asthmatic patient will have a constricted airway, so their tidal volume will be less. So if we give them 100% oxygen instead of the 21% that they were breathing, that will hopefully increase your minute volume and the amount of actual oxygen that reaches your alveoli. On arrival at the emergency scene, you find an adult female patient who is semi-conscious. Her respiratory rate is 7 per minute. She appears pale and slightly blue around her lips. Is this patient in respiratory failure? And if so, what signs and symptoms indicate this? Does the patient require artificial ventilations? So yes, this patient is in respiratory failure. You can see that because of the change in her color, her change in her mental status, and her respiratory rate being significantly lower than what's acceptable. So this patient would require artificial ventilations. Big key is an inadequate respiratory rate, signs that the body is not being perfused because it's turning blue, and she is not fully conscious, so she has a big marked change in her mental status. So this person does require artificial ventilations. So that brings us to the end of this chapter. I know it was a very long one, especially when you combine it with chapter 9, which a lot of this material goes hand in hand. There's a reason we teach these 2 chapters together. So A lot of material to cover. Most of this we're going to be reinforcing with hands-on skills. So don't worry if you don't understand it the first time through, because the hands-on stuff will really seal us in. We're both going to show it and have you do most of these procedures. So hopefully you guys feel a little bit comfortable with airway management, and we'll see you next time.